From Microbe TV, this is Infectious Disease Puscast, episode 21, recorded on February 1st, 2023. I'm Daniel Griffin, and joining me today is Sara Dong. And if you heard a little bit of a sigh, so close to Groundhog Day, my favorite day of the year to be recording. But Sara?
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. Now, on to the literature, shall we?
All right, I'll be opening up the viral section, but remember to listen to This Week in Virology. All the This Week in Virology, including those clinical updates for timely viral-related information and some deep dives. But I enjoyed this article. It reminded me of back when I graduated from medical school, and my dad wanted to know why they called it a cold if it had nothing to do with temperature. Well, the article, The Impact of Cold Ambient Temperature in the Pattern of Influenza Virus Infection, was published in Open Forum Infectious Disease. These investigators reported data suggesting that high ambient temperature and then a drop in temperature was associated with an increase in the risk of infection. So the highest risk of infection was attributed to a steep fall in temperature in a relatively warm environment. Thus, getting cold was associated with getting a cold.
We recently heard that Janssen and global partners decided to discontinue the phase 3 Mosaico HIV vaccine clinical trial. The study's independent data and safety monitoring board determined that the regimen was not effective in preventing HIV infection compared to placebo among the study participants. No safety issues with the vaccine regimen were identified. And just as a side note, the study evaluated an investigational vaccine regimen. It contained a mosaic-based adenovirus serotype 26 vector. And this was administered during 4 vaccination visits over the course of a year. And there was a mix of soluble proteins, clade C/mosaic GP140, adjuvanted with aluminum phosphate. So those were also administered at visits 3 and 4.
All right. Bit of a disappointment, but the article Randomized Trial of Vaccines for Zaire Ebola Virus Disease was recently published in the New England Journal of Medicine, and encouraging results demonstrating no safety concerns and good antibody responses at 12 months. All right. Now, this is a disease that still challenges me. The article, well, many diseases still challenge me for full disclosure, but just highlighting one at the moment. The article, PD-1 blockade and lenalidomide combination therapy for chronic active Epstein-Barr virus infection, was published in CMI, and unfortunately is behind a paywall. But let me go through. As per their introduction, primary Epstein-Barr virus EBV infection is usually asymptomatic, but sometimes progresses to infectious mononucleosis and then resolves spontaneously after the onset of EBV-specific immunity. But rare patients infected with EBV develop disease that does not resolve. A subset of patients cannot control EBV infection, and tissues are infiltrated by EBV-positive T cells, NK cells, or sometimes B cells. They suffer significantly elevated levels of persistent EBV DNA in peripheral blood, and this entity is known as chronic active EBV disease, or CAEBV. CABV, I guess I'll pronounce that. So CAEBV is a disease with high mortality, and the 3-year overall survival in patients with uncontrolled disease is only 16.7%. So here the investigators performed an open label, single center, prospective study to examine the activity and safety of PD-1 blockade combined with lenalidomide in these chronic Epstein-Barr virus infection patients. It was a whole complicated regimen where they went about doing this treatment. And they reported that this therapy for CAEBV treatment had an overall response rate of 54.2% and a persistent EBV DNA undetectable rate of 45.8%. The adverse events were mainly grade 1 or 2. Um, and in a complicated part of the paper, they found possible predictors for the different therapeutic effects of PD-1 blockade in this chronic Epstein-Barr virus infection. All right, and we will now move into bacterial. Be sure to listen to This Week in Micro. I was listening to that earlier today. The article, Outcomes of Daptomycin plus Ceftaroline versus Alternative Therapy for Persistent Methicillin-Resistant Staph aureus MRSA Bacteremia, was published in International Journal of Antimicrobial Therapy. The introduction is really good for giving the study context. And as they remind us, MRSA bacteremia is a serious illness and is associated with complications that result in a high rate of morbidity and mortality. Persistent MRSA bacteremia has been associated with poor outcomes, serious complications. In two large prospective cohort studies, each additional day of MRSA bacteremia significantly increased mortality risk compared to that of patients whose MRSA bacteremia resolved after a single day. So they actually reference these studies. So if people want a deeper dive, they can follow those. The most recent IDSA treatment guidelines for MRSA define treatment failure and persistent bacteremia as lasting equal to or greater than 7 days, and recommend consideration of high dose daptomycin, so 10 milligrams per kilogram per day, in combination with another agent such as linezolid, trimethoprim sulfa, or a beta-lactam antibiotic for treatment of persistent MRSA bacteremia. Now, based on the evidence that each additional day of MRSA bacteremia significantly increases mortality risk, there's a suggestion by some that 7 days may be a long time to wait. And a full Constantine unit is a bit too generous. There has been a randomized open label pilot study of 40 patients who received daptomycin slash CPT or standard of care monotherapy as initial treatment. Treatment with the daptomycin CPT resulted in a significant reduction in hospital mortality, 0% versus 26% in the standard. So here are the results of a retrospective single center study of adult patients who underwent a change in antibiotic therapy for persistent MRSA bacteremia, defined as blood cultures positive for MRSA despite at least 72 hours of initial anti-MRSA therapy with vanco or daptomycin at a large academic medical center between January 2014 and July 2020. A total of 68 patients with persistent MRSA bacteremia were included in the study and had initial anti-MRSA therapy with vancomycin or daptomycin switched to the DAPT CPT or alternative therapy. So we've got 43 versus 25. There were no statistically significant difference between groups, except for higher average baseline creatinine clearance among the patients that were switched. So a few comments. Since this is behind a paywall, many will not be able to spend time digging through this whole paper. When I did, I noticed that they say that these patients had initial anti-MRSA therapy with vanco or daptomycin. They really should just say everyone was on vanco except for one person, mostly non-therapeutic vanco levels with a mean vanco trough of 10.9 micrograms per ml. That one person on dapto. Perhaps a more important question is how do we avoid getting to persistent MRSA bacteremia lasting equal to or more than 7 days? Now that dapto is generic and costs about $29 a day, should we be using more dapto? And if we do use vanco, it is about time to be using AUC/MIC guided dosing.
I have a new clinical alert from January 19th, 2023. This is from the Massachusetts Department of Public Health about detection of a novel strain of multi-drug non-susceptible Neisseria gonorrhea with reduced susceptibility to ceftriaxone, cefixime, and azithromycin, and resistance to ciprofloxacin, penicillin, and tetracycline. So the patient presented to primary care with urethritis without a known exposure to gonococcal infection or any sort of initial disclosure of risk factors. There was no recent travel reported suggesting their acquisition was likely in Massachusetts, but we don't know the travel patterns of their partners. Ceftriaxone at 500 milligrams IM was effective at clearing the infection in this case, but this is the first isolate identified in the States to demonstrate resistance or reduce susceptibility to all drugs that are recommended for treatment. Enhanced surveillance identified a second isolate that likely has reduced susceptibility. And so just a reminder that the 2020-2021 CDC guidelines recommend ceftriaxone at that 500 milligram IM dose for those patients who weigh less than 150 kilos, or 1 gram of ceftriaxone for those who weigh over 150 kilos.
All right. Yeah, I caught this, and actually, this was the talk of the clinic, so to speak. Not really the talk of the town, the talk of the ID clinic.
Yeah.
And actually, for a discussion, there was an article, "Efficacy of Ertapenem, Gentamicin, Fosfomycin, and Ceftriaxone for the treatment of anogenital gonorrhea." The Nabago, a randomized non-inferior trial published in the Lancet, actually last January. Just sort of looking at potential options here. So ceftriaxone may not be our only option in the mix. All right. This seems like a good section to discuss the article, "Getting to Zero: Impact of a Device to Reduce Blood Culture Contamination and False Positive Central Line Associated Bloodstream Infections," published in Infection Control and Hospital Epidemiology. We struggle with this issue of a certain rate of, I like to call them, procurement contaminations, where we get a report of positive blood culture, and in some circumstances, this triggers unnecessary antibiotics, delays in stay, or more investigation. So one great advance has been rapid PCR, giving us preliminary information about the positive result in less than 3 hours. My day is often punctuated by alarms letting me know it is time to check back to see if an organism consistent with a procurement contaminant such as coag-negative staph, or something that requires prompt initiation of therapy such as Staph aureus, is in the isolate. So these are the results of a single-center, quasi-experimental, prospective cohort study wherein phlebotomists used traditional venipuncture with or without the use of an additional specimen diversion device, while registered nurses use traditional venipuncture. Now, here are the results. Phlebotomists using traditional venipuncture had a 2.3% BCC rate, blood culture contamination, by the way. Phlebotomists using the ISDD, the initial specimen diversion device, they had a 0% blood culture contamination rate, and the RNs, their rate was 0.8%.
Oh, I need to look at that. And as you were explaining, I was like, oh, I really just want to search a picture to know what this diversion device looks like. It's interesting. This next one I also found quite interesting. So it's from JAC, Antimicrobial Resistance, addition of anaerobic coverage for treatment of biliary tract infections, a propensity score matched cohort study. This study is from Toronto and set out to evaluate whether additional antibiotics that target anaerobes, including Bacteroides, were associated with improved clinical outcomes in patients with acute cholecystitis or ascending cholangitis. This was a retrospective, like I mentioned, propensity score matched cohort of adult patients admitted from 2015 to 2021. And their primary outcome was a composite of mortality within 30 days, or relapse within 90 days of source control, or completion of antibiotics. And then as their secondary outcomes, they looked at length of stay, duration of antibiotic therapy, and adverse drug reactions. Of about 400 patients that were included, 209 were treated without anaerobic coverage and 189 received anaerobic coverage. There was no significant difference in the primary outcome between the propensity matched patients who received additional anaerobic coverage versus those who didn't. So an adjusted odds ratio of 1.223 with a 95% confidence interval of 0.69 to 2.22. And they found that those who received anaerobic coverage had a longer length of stay and a longer duration of antibiotic treatment. And ultimately, the authors suggested omitting anaerobic coverage may be a safe stewardship intervention. I think I wanted to just point out that the IDSA guidelines for cholecystitis and cholangitis do recommend empiric treatment with cephalosporins alone for mild to moderate cases and reserve addition of metronidazole or other antibiotics with anaerobic coverage for when patients have uh, concurrent anaerobic bacteremia or when there's evidence or suspicion of a biliary enteric anastomosis issue. I suspect that many of us work in locations where adding anaerobic coverage is just typical and part of what tends to be done. The patients in this study who did receive anaerobic coverage were a little bit older. They were more likely to be in the ICU. They more often had malignancies or hepatopancreatic biliary cancers. So things that I think kind of make sense. And then those who had positive biliary fluid or blood cultures were seemed to be more likely to have anaerobic coverage added, although there were not anaerobic organisms isolated from any of the blood cultures in the group. Um, and I think an interesting exclusion, anyone who received piptazo or carbapenem were not included based on the assumption that those patients had more severe illness or history of multi-drug resistant pathogens. So I said all that, and even though this is retrospective, I think in general my bias is that I buy into the idea that anaerobes often are not as much a contributor, or maybe we give them a little bit more credit than they need, barring having actual bacteremia. So maybe I had a little bit of bias when I read it, anyways, to be on board with scenarios where you may not actually need that extra flagell.
Yeah, it's interesting because they excluded right here, Sarah, those on
Yeah,
zocin for those of
yeah,
you um, who
yeah,
don't know what that is. Um, um, it's
yeah.
amazing how often at a community hospital, everyone gets on zocin for everything.
Mhm.
It's cholecystitis, and they get on zocin. It's pneumonia, and there may have been aspiration, and next thing you know, zocin is aboard. There seems to be a real excitement about covering anaerobes and Pseudomonas in so many different situations when, a 1 gram a day of ceftriaxone may actually more safely do the job.
Yeah.
All
Yeah.
right. The article, High Dose Cefepime versus Carbapenems for Bacteremia Caused by Enterobacterales with Moderate to High Risk of Clinically Significant AMP-C Beta-lactamase Production, published in OFID. So these are the results of a retrospective cohort study of hospitalized patients with E. cloacae, K. Aerogenescer. See, I'm having trouble. C. friundi bacteremia from January 2015 to March 2022, receiving high-dose cefepime or a carbapenem, and they reported similar 30-day mortality. All right, I like this next area. I'm a big fan of IGRAs. So, what are those? The article, assessing the diagnostic performance of a new commercial IGRA, interferon gamma release assay for Mycobacterium tuberculosis infection. A systematic review and meta-analysis was published in CID. So here they compared 6 new IGRAs, hereafter index tests: QFT plus, quantiferon plus CLIA, QIA reach, Wante TB IGRA, standard ETB Furon, TB spot, T cell select, and they're comparing these with WHO endorsed tests for tuberculosis infection. So 87 studies were included, different numbers to evaluate different of these tests, and drum roll, despite small differences, they all looked very similar in terms of sensitivity and specificity. I will admit being a bit partial to the T-spot, which happens to be less expensive than that quantiferon gold, less likely to give an indeterminate result, and corrects for low levels of lymphocytes.
All right. I have an article. I've actually pulled some similar, what they call state of the art reviews before. This is from the Journal of the American College of Cardiology, JACC. Infective endocarditis after transcatheter aortic valve replacement. Many likely already know and have had cases of endocarditis after, I'm going to say TAVR, which is seen sort of like a subtype of prosthetic valve endocarditis, but has its own challenges. And often I think navigating the role of surgery and what to do next is quite difficult, and sort of a additional layer beyond prosthetic valve endocarditis. And unfortunately, there's a pretty dismal prognosis for most patients who are in this situation. I think it's just a really nice review. I try to pull out just a couple of the highlights, and then people can go check out the paper. The first one is to point out that the incidence of TAVR endocarditis is 0.3 to 2 per 100 person years. So it's similar to that after a surgical aortic valve replacement, and has actually remained stable over time despite some improvements in diagnosis. And what I think is sort of the evolving profile of the patients who get TAVR or are selected for it in most places, I think, have sort of TAVR teams that decide which patients are candidates. Endocarditis after TAVR is most commonly due to Enterococcus and Staph aureus, and it's associated with high rates of complications and in-hospital mortality. In addition, patients who survive their hospitalization typically have poor long-term prognosis. And some of the risk factors for endocarditis in the setting can be what the authors broke apart as patient related. So, younger male patients, those with comorbidities, those, of course, who've had endocarditis in the past, and high BMIs. And there can also be risk factors related to the procedure itself. So, some examples of that are moderate to severe aortic regurgitation, the actual sort of placement anatomically of the TAVR being a little bit lower, if there's a valve within a valve, and a couple other examples. So I think there's a lot of questions and research that we can think about in the future, particularly thinking about antibiotic prophylaxis, because I think a lot of people preoperatively are not actually probably giving enterococcal coverage. I suspect that a lot of places are covering staph, and also just thinking about novel imaging techniques when we're in this scenario. And I felt like everything I pulled this week were sort of announcements or review articles, but another really great overview paper that came out since our last episode was from the New England Journal of Medicine on periprosthetic joint infection. I feel like we talk about PGI on most episodes of Puscast, but for those who want a wonderful overview with some nice illustrations, you can definitely check out that review as well.
Well, that's great. All right. The article Discordant clinical and microbiological outcomes are associated with late clinical relapse in clinical trials for complicated urinary tract infections, published in CID. Now, in this study, the investigators analyzed participant data from 13 phase 3 clinical trials submitted to the FDA, their theme there. Outcomes were determined at the test of cure visit, the TOC, recommended to occur at least 5 days after therapy, and at the late follow-up visit, the LFU, recommended to occur 21 to 28 days after randomization. Clinical and microbiological success were defined as the resolution of the UTI symptoms present at study entry with no new symptoms, or clinical cure, and a reduction in density of the original pathogen to less than 10 to the third CFUs per milliliter on urine culture, so colony forming units. That's your microbiological eradication. Now, they reported that 70.7% were concordant successes at the TOC, the test of cure visit. 18% were discordant failures, and 6.7% were concordant failures. So clinical failure and microbiological persistence. Discordant participants were at an increased risk for clinical failure at the LFU, the late follow-up visit, and the risk of late clinical failure increased with time. I thought this was interesting because I'm not so sure that these 5-day microclinical, test of cure visits and these late 21 to 28 day microclinical visits are really standard of care. I think, in general, we might check in with the patient. This is your isolate. This is the antibiotic. We know the sensitivities. Give us a holler if you have problems. But I don't think it's routine that we're jumping in at day 5 and then jumping back in at 21 and 28 day with clinical and micro assessments. Sarah?
Yeah, like you were saying, I feel like I am not typically getting repeats, but I think generally I'm seeing patients that they're not coming back with symptoms, so they're probably not who we're sort of looking at in this group. But even for complicated UTI, I don't know that I have much of a habit of rechecking.
I'm sort of
So
wondering what you do at day 28 when they're asymptomatic, but they have bacteria still in the urine, because that to me would be asymptomatic bacteria. And am I going to treat that? I will get kicked
yeah.
out of the ID club.
Well, I am rounding out our bacterial section. The article Real World Use of Basilotocimab and Fecal Microbiota Transplantation, or I'm going to say FMT, for the treatment of Clostridioides difficile infection. So this is published in OFID. The results are from a retrospective study conducted in a university hospital in Spain, where adult patients received bezilotoximab, 10 mg per kg, which is a humanized monoclonal antibody that binds C. diff toxin B, or they got FMT from, this is a period from 2018 to 2021. The primary objective was to evaluate the effectiveness of Bezlo or FMT in preventing early within 8 weeks or late within 1 year C. diff recurrences. And so of almost about 1,400 C. diff episodes at the institution, only 8.5%, 117 patients, were treated with bezilotoximab or FMT. And I think that's one key takeaway, is just that we don't, or at least in this setting, and I'd say in general, like we're not necessarily using Bezlo or FMT that often. So the N here is pretty small for the groups. It's about 40. They reported no significant differences between Bezlo and FMT in preventing early C. diff recurrences, 19.6% versus 24.5%, which is a p-value of 0.5, or late recurrences, which was 9.8% versus 18% with a p-value of 0.3. I think the other thing that we often are talking about in these settings is cost. And I don't know, at least here, how much of a difference bezilotoximab versus FMT have as the intervention themselves. Um, and the IDSA guidelines recommend or suggest Bezlo as a co-intervention with antibiotics rather than antibiotics alone. And so I feel like the issues that we also run into are the cost of fidaxomicin. So maybe it would have been, hopefully it'll be helpful in the future to have more of like a vanc plus Bezlo versus fidaxomicin plus bezilotoximab, fidaxomicin alone. Like I think there's a lot of combinations here that maybe help us guide how to combine these for our patients.
All right. And we will now enter into the fungal section. The article Blastomycosis in New England, 5 cases in a review, was published in OFID. And here they describe 5 cases of infection with Blastomyces dermatitidis, which were likely acquired in New England between 2011 and 2021. I think the big thing here is to reinforce that New England is part of the geographical range of blastomyces.
Yeah, every episode we can just talk about how endemic fungi are everywhere. Um, my paper is from Transplantation and Cellular Therapy, American Society of Transplantation and Cellular Therapy, Series number 6, Management of Invasive Candidiasis in Hematopoietic Stem Cell Transplant Recipients. So this is a really nice resource and an update. So we know that post-transplant, or I should say post-hematopoietic cell transplant candidal infections are usually due to translocation of GI flora during post-conditioning mucositis. And the antifungal recommendations in this align with recent IDSA guidelines, which is first-line therapy with an echinocandin, particularly given most of these stem cell transplant patients have been exposed to azole prophylaxis in the past. There's no specific combination therapy that is routinely recommended. There is a note to strongly favor removal of a CVC in a neutropenic patient with candidemia when feasible. But I did pull out one point that there's still a recommendation, or there is a recommendation for a dilated eye exam should be performed in all patients with invasive candidiasis within the first week after neutropenia resolution to rule out candida and endophthalmitis. I'm curious if people actually do this, and If they are they really finding anything? We've certainly touched on eye exams in sort of more general settings, but this specifically being checking after their neutropenia resolves, which I don't know.
Yeah, there's been a heated debate about the lack of evidence-based of doing this.
Yeah.
So people, yeah, we should probably put in a link to one of our prior Puscasts where there was some very eloquent musings about, what are we doing with all these eye exams?
Yeah.
All right. The article Short Course of Antifungal Therapy in Patients with Uncomplicated Candida Bloodstream Infection. Another case of less is more in the clinical setting. That's actually in the title. Published in OFID. Here they compare patients with uncomplicated Candida bloodstream infection that were treated for 5 to 11 days versus 12 to 24 days. The risk of 90-day mortality was not different between the groups, and the risk for recurrent Candida bloodstream infection with 1 year of completing therapy or for all-cause 1-year mortality did not differ between the groups. All right. Moving into parasitic, be sure to listen to This Week in Parasitism. The article Parasites and Childhood Stunting, a mechanistic interplay with nutrition, anemia, spelt the way the Brits do it, gut health, microbiota, and epigenetics was published in Trends in Parasitology. So this is one of those things that everyone thinks is true, but the evidence and the mechanism is not entirely clear. Now, they start by pointing out that an estimated 149.2 million children under the age of 5 were physically stunted in 2020, defined as falling at least 2 standard deviations below the height for age WHO criteria. And then, I'll just sort of say this is a musing paper. It's it's a thought provoking paper. They talk about all the different proposed mechanisms that might be driving this: appetite suppression, diarrhea, some environmental enteric dysfunction, perhaps the parasites perturbing the gut microbiota, systemic inflammation, chronic immune activation, anemia, as mentioned, or some modification, interesting, of the epigenetic signature, all potentially leading to childhood stunting. So I recommend this as a nice thought provoking article. All right. And we've just got a few here to wrap it out in miscellaneous. The article comparing complication rates of midline catheter versus peripherally inserted central catheter PICCs. So midlines versus PICCs, a systematic review and meta-analysis published in Open Forum Infectious Disease. Here the authors are comparing midlines and PICCs. The authors conducted a systematic review and meta-analysis of RCTs and observational trials. The primary outcome was catheter-related bloodstream infection and thrombosis. Secondary outcomes were mortality, failure to complete therapy, catheter occlusion, phlebitis, and catheter fracture. Of 8,368 citations identified, 20 studies met eligibility criteria, including only 1 RCT, 19 observational studies. Midline use was associated with fewer patients with catheter-related bloodstream infection compared to PICCs. Odds ratio of 0.24. No significant association was found between catheters when evaluating risk of localized thrombosis and pulmonary embolism. Surprised by that. A subgroup analysis based on location of thrombosis showed higher rates of superficial venous thrombosis in patients using a midline, and that was an odds ratio of 2.3. They did not identify any significant differences between midline and PICC for any of the secondary outcomes. So those of us in practice are likely aware of potential complications from catheter infections, and there is a significant amount of effort to make prudent decisions about IV placement. I look through the literature, and several studies give information about the cost of placing a PICC ranging from $286 to $382, with most costs being due to the catheter itself, but also comparing blind bedside placement to guided positioning by an interventional radiologist, suggesting that in some settings, IR placement may actually be more cost effective due to less need for repositioning. Now, in contrast, midlines might cost less than $100, but there's a wide range of reimbursement out there, so actual costs or charges may vary. Sounds like an advertisement. From an ID perspective, the movement toward limiting prolonged courses of IVs may open more opportunities to just use those midlines to effectively treat patients without requiring hospitalization simply for IV therapy or to avoid IV therapy completely. So just think about a lot of these studies we talk about when they're able to drop that duration of therapy to less than 30 days, you may be dropping yourself away from requiring that PICC line. All right. And we have a new pathogen. The article, Novel Prion Strain as Cause of Chronic Wasting Disease in a Moose, Finland, was published in Emerging Infectious Disease. Previous studies using gene-targeted mouse models of chronic wasting disease demonstrated that Norway and North American cervids are infected with distinct prion strains that respond differently to naturally occurring amino acid variation at residue 226 of the prion protein. So here they demonstrated that the strain properties of Finland moose chronic wasting disease prions are different from those previously characterized in Norway CWD. These findings add to a growing body of evidence for a diverse portfolio of emerging strains in Nordic countries that are etiologically distinct from the comparatively consistent strain profile of North American chronic wasting disease. So the reasons to go vegetarian are growing. And I will close it. This is our last one. I'm going to close this out. A very positive paper, I will say. Agreement of respiratory viruses detection between nasopharyngeal swab and bronchoalveolar lavage in adults admitted for pneumonia, a retrospective study published in CMI. This retrospective analysis was performed in one French academic hospital on consecutive adults from 2012 to 2018 and tested by nasopharyngeal swab and bronchoalveolar lavage within 24 hours by multiplex PCR. The agreement in pathogen detection overall between the swabs and the BAL were found to be very good. Overall agreement was 83.7%.
It is a positive, positive note. That brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. You can find them on all your podcatchers, but consider supporting the science shows of Microbe TV at microbe.tv/contribute.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.